The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hello, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. Before I get started on this week's topic, I've been thinking about something I said on the show last week about alpha-1 antitrypsin deficiency. I was listening to that episode in the car on my way to work the day it came out, and I thought, wait a minute, if alpha-1 antitrypsin is made in the liver, wouldn't a liver transplant be curative? So I went back and looked it up, and I found some sources that said that that can be the case. I don't know then why liver transplant is not like the first treatment for alpha-1 antitrypsin, if that can be curative. But anyway, that's been nagging at me, so there you go. There's your correction. Okay, continuing the Alphabet Soup series this week. I was having a little trouble coming up with something I was interested in that started with the letter B, but I settled on Brugada Syndrome. This is a cardiac condition that's pretty rare, and I will confess that I only recently learned about this. Most of what I know about EKGs comes from my paramedic training. The EKG training that you get in nursing school is really very, very limited, superficial, and I don't remember spending much time on that in my practitioner training either. I suppose if you add a cardiology concentration or certification as a nurse practitioner, you would learn more about that. But in general, not a whole lot of training on EKGs. But in paramedic school, you spend like an entire semester only talking about cardiac stuff and EKGs. So I would go so far as to say that really any paramedic is probably second only to heart doctors in their knowledge of interpreting EKGs and just cardiac stuff in general, at least acute cardiac issues. But this Brugada syndrome, I do not recall learning about ever. The only reason it's on my radar actually is because of the EMS subreddit. They have a lot of really smart conversations in there, and sometimes people will post test questions or pictures of EKGs asking for help about what it is. And I kept seeing this Brugada syndrome coming up in people's answers to questions, and I'm like, what is that? Why do you all know about that? And I don't. So this is actually a genetic disorder that causes a little abnormality in electrical conduction through the heart. It's an abnormality that can lead to ventricular dysrhythmias that lead to sudden cardiac arrest. So it's pretty rare, but pretty important. The underlying issue is a mutation in genes that code for sodium channels in the heart, which in turn affects electrical conduction. You can see this on a 12 lead, and the big abnormality that you see with Brugada syndrome is persistent ST elevation in V1 and V2, followed by inverted T waves in V1 and V2. They divide this into two subgroups based on whether or not a person has any symptoms. So if you just have that on your EKG and there are no clinical signs or symptoms, they call it Brugada pattern. But if you have some symptoms going along with it, then they call it Brugada syndrome. This is not something that tends to go along with any structural heart disease. So people who have congenital heart defects or acquired structural heart disease like valvular disease or ventricular hypertrophy would not be more prone to this. This is just something that you have the bad luck of being born with. This is not usually diagnosed in children. It usually shows up sometime after the early 20s and before the late 60s. It can be found incidentally on an EKG that's done for some other reason, or if you're actually having some kind of ventricular arrhythmia. Sometimes the pattern on the EKG can come and go. Fever tends to bring it out, as well as autonomic dysfunction and some different medications, including psychotropic drugs, anything that messes with sodium channels, which include tricyclic antidepressants, lithium, and oxcarbazepine. Some antiarrhythmic drugs are sodium channel blockers, including flecainide and procainamide, as well as some anesthetics, including procaine, bupivacaine, and propofol. I'll put a link in the show notes to a website called brugadadrugs.org, which has an extensive list of medications that ought to be avoided by people with Brugada syndrome. One illicit medication that can bring this out is cocaine. It's certainly not unusual to see people with heart issues. I'm thinking of like heart attacks that seem to be induced by cocaine use, but it can actually directly cause a ventricular arrhythmia through this mechanism as well. How about that? In case you needed another reason to avoid cocaine. Alcohol is another thing that can unmask Brugada syndrome. If you have Big metabolic disturbances like very high potassium, that can also bring this out. As far as symptoms, unfortunately, if this manifests as a clinical symptom, it's probably going to be a ventricular arrhythmia. So the first symptom here may be, death, which is not exactly conducive to picking this up early. These arrhythmias leading to sudden cardiac arrest related to Brugada syndrome tend to happen more often at night, more often while the patient is asleep. They're not usually related to exercise like you would think of with MI secondary to coronary artery occlusion. The most common arrhythmias are VFib and polymorphic VTAC, aka torsades. Apparently, monomorphic VTAC is a little less common with Brugada syndrome. People with this are more likely to have disordered breathing during sleep, in case you needed another reason to be ordering sleep studies. I love how sometimes these medical literature resources will just so understate things. I'm reading this paragraph that's talking about nocturnal agonal respiration, which is gasping breaths during sleep that may represent cardiac arrhythmias that correct themselves. And the next sentence says, this is generally considered an ominous symptom. You think? Of course, ventricular arrhythmia can also present with syncope if it's a more transient kind of situation. These folks can present with AFib, which obviously would be preferable to VFib or polymorphic VTAC. So sometimes that can be the first presentation of the disease. Apparently, that's about 10 to 20% of people with Brugada syndrome will have AFib. If we run across somebody with this, evaluation consists of checking for structural heart disease. This would be in the case where a ventricular arrhythmia is the presenting symptom. While Brugada syndrome is not related to structural heart disease, ventricular arrhythmias can certainly be caused by structural heart disease. So if that's the first thing that happens, we want to make sure that there is no underlying structural heart disease that's causing it and not the Brugada syndrome. Of course, the EKG, in addition to the changes I mentioned before, a J wave, which is a little elevation right before the ST segment starts. That's as a result of abnormal repolarization of the right ventricular outflow tract. One thing you do not see with Brugada are changes characteristic of a right bundle branch block, which you might think would be present in that situation, specifically a widened S wave in the lateral leads. You can see prolonged QT. You can also see increased voltage and duration of the S wave. But really the key finding on the EKG is the persistent ST elevation in V1, V2 with the inverted T waves right behind them. Of course, these folks are also going to undergo testing for any other kind of heart disease. So that may include stress testing or cardiac MRI. If there's question about whether it's Brugada or not, they can actually do a drug challenge to try to bring out that pattern on the EKG. This is kind of sort of similar to like a chemical stress test where they give medication to stress the heart and see what happens. In this case, we're giving them a sodium channel blocker to see if we can bring out that Brugada pattern on the EKG. So typically they're going to use one of those sodium channel blocking antiarrhythmics I mentioned earlier, flecainide or procainamide. There are a couple others called ajmaline, AJMALINE, and pilsicainide, PILSICAINIDE. About 1 or 2% of the time, these drug challengers are going to cause ventricular arrhythmias. So obviously those have to be performed in the appropriate setting with the appropriate resuscitation equipment on standby. Sometimes they will have patients wear an insertable monitor, so like a loop recorder around, if they're not sure about the risk of having a life-threatening arrhythmia. As far as what to do about this, once you know a person has it, there's really not a way to cure it as far as I can tell. Pretty much the goal is just to avoid things that might make these people more prone to developing the ventricular arrhythmia. So because we know fever can trigger it, they should take antipyretic medication if they develop fever for any reason. Of course, avoiding all the medications that could potentially make this worse. For super high-risk people, they can put in an ICD. It seems that putting people on medications to prevent ventricular tachyarrhythmias has not been effective in people with Brugada syndrome. But if they have to do that, they can try quinidine or amiodarone. Catheter ablation can also be an option to terminate that abnormal conduction in the right ventricular outflow tract. And that's pretty much it as far as treating an individual patient. They do recommend screening relatives of people who have this because it's a genetic situation. The recommendation is that all first-degree relatives of somebody who has this should get a clinical history and a 12-lead EKG. With the history, of course, you're looking for any prior episodes of syncope, cardiac dysrhythmias, anything that would point you in that direction. They do suggest genetic testing eventually for all patients with Brugada syndrome. I don't think it's typically a way to diagnose it, really, but that's very helpful for knowing how likely the relatives of somebody with this are to also have it. The recommendation is to continue screening first-degree relatives every 1 to 2 years with a 12-lead, since this is something that might not come up until later in life. They don't typically do testing on first-degree relatives who don't have any EKG manifestations of the syndrome. And I think that's pretty much all there is to say about Brugada Syndrome. I'm going to post another link in the show notes to a website called Life in the Fast Lane. That's an excellent resource for learning about EKGs. It has a really good overview of Brugada Syndrome, as well as several pictures where you can see the different EKG changes. There are a couple different types of EKG changes that I didn't talk about because they're a lot less specific for Brugada. There's a type 2 and a type 3, and you can see all that on the Life in the Fast Lane site. Thanks to the EMS, and I believe there's an ECG subreddit also. Thanks to those groups for making me aware of this condition. It's definitely something I've been keeping more of an eye out for in our routine EKGs that we do in the office. If there's anything to add, if you know anything about Brugada Syndrome that I missed, if you have any other feedback for me, feel free to get in touch. If you have any suggestions for the next installment of our Alphabet Soup series here, something that starts with a C that you'd like to hear about, let me know. Special thanks to our Patreon supporters. Thanks to all of you for listening. I hope you have a great week, and I'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.